So someone wanted to know what should be the workup of opsoclonus. And opsoclonus is bilateral, conjugate, multivectorial, rapid movements, rapid because they're back-to-back saccades with no intersaccadic interval. So it looks like this. If it's just horizontal, we call that ocular flutter. But the workup of flutter and opsoclonus is the same, and the differential is the same. And as with anything in medicine, the differential is always the same for every single thing on this planet, and you have to have some sort of mnemonic device, vitamin D or Vinditch MD or whatever you're using, because that finding right there doesn't tell you what the cause is. It just tells you that something's wrong with the neural network for saccades. And in this case, in the pons, there's a gas and a brake. So you've got pause cells that are like a brake, and you got burst cells in your pons that are like the gas. And so you have to have supranuclear control of your pons to keep your eyes from jumping when they're not supposed to jump. And so if you have stepping on the gas, or if your brake is broken, you'll have an out of control car. So we know that something's wrong with the network. We know that it's a problem in the omnipause or burst cells that are controlling the stimulation or inhibition of the saccade. And now you have to use some sort of mnemonic device. Could it be a vascular lesion? Yes. Infectious, inflammatory, infiltrative? Yes. Traumatic? Yes. Anaplastic, metabolic, idiopathic, which is super common, neoplasm, degenerative, dystrophic, whatever your mnemonic is, the presence of opsoclonus only tells us we have a problem. And so we're going to start with the easy thing, which is the MRI. And you know you're going to be directing that MRI towards the brainstem and the pons. So if we see a structural lesion like a neoplasm or a demyelination or a stroke, you're done. That's the cause. It's when the MRI is negative that the workup becomes harder. So it has to be something we can't see. And of course, you have to do the usual suspects in that setting. And the usual suspects for opsoclonus or ocular flutter when the MRI is negative is antibodies. And those antibodies can be autoimmune paraneoplastic antibodies. And so in a kid, that's neuroblastoma, causes dancing eyes and dancing feet. So they're ataxic, they have myoclonus, and they have the opsoclonus. And so you're going to be looking for a occult neuroblastoma somewhere. And you can test the paraneoplastic antibodies, but really you're going to do a whole body imaging or a whole body PET scan to look for cancer. And the same in adult, but instead of neuroblastoma, it's usually some other cancer, lung cancer, breast cancer, whatever it is, you got to look for cancer. The alternative is that it's autoimmune, non-paraneoplastic, it's not cancer, and you still got to do the antibodies. You're going to do a lumbar puncture to look for evidence for infection or inflammation or post-infectious. The most common is actually post-infectious. So you had some sort of post-infectious meningoencephalitis, and now as a residual, you have the opsoclonus. So opsoclonus, bilateral, conjugate, chaotic, multivectorial, back-to-back saccades, flutter, horizontal. Have the differential in mind. Imaging for a structural lesion. Look for the antibodies, paraneoplastic, non-paraneoplastic, and post-infectious. These are the most common causes of opsoclonus and ocular flutter.